webinar. Our speakers for today will be Professor Eka. Professor Eka is Professor and Chair Department of Neurosurgery, Faculty of Medicine, Balita Harapan University, Salem Hospital. His topic for today will be building advanced neurosurgical treatment. And our second speaker will be Miss Jin Yan. She's a nurse clinician, advanced practice nurse, rehabilitation medicine, Singapore GH. Unfortunately, Miss Jen Han today won't be with us, but she has sent her pre-recorded presentation. And her topic will be neuro rehabilitation for traumatic brain injury patients. And Sister Shani is a senior nursing officer attached to Sri Citra Turina Institute for Medicine, Science and Technology, India. She will give us a case presentation on neuro rehabilitation. Our chairs for today will be Mr. Sunny Roy, and he's a nurse practitioner attached to the Neurosurgical Outpatient Department, Salem Hospital. Our second chair will be Miss V. Ling, and she's the nurse clinician, specialty nurse, rehabilitation medicine attached to Singapore GH. Our commentators for today will be Professor Salim Abdul Rauf, Neurosurgeon in Chief, Abdul Rauf's Institute of Neurosurgery, Founding Chairman, Department of Neurological Surgery, St. Louis University School of Medicine, USA. Global President, Walter E. Dandy Neurosurgical Society, and also the 17th President, Society of Brain Mapping and Therapeutic, past Vice President, Congress of Neurological Surgeons, and also past Secretary General, World Federation of Skull-Based Society. And our next commentators will be Professor Dovshat Mabadelai. He's a neurosurgeon, Republican Scientific Practical Center of Neurosurgery, Skull-Based Neurosurgery, Tascan. And also Republican Clinical Hospital, Department of Neurotraumatology, Tascan. And he is also member of USPEC, Association of Neurosurgeons, Wichita Benton Fellows, Alumni Association, Regional Responsible Neurosurgeon. So without further ado, may I invite our first chair, Mr. Roy, to introduce Professor Eka. Mr. Roy, please.
Okay, thank you, Missy. Good evening, everyone. Good morning. Welcome to all participants in the 6th ACNN webinar today. The Honorable Professor Kato as a President of Asian Congress of Neurological Surgeons, Professor Eka as a speaker, Prof. Salim, Prof. Dishat, Mrs. C, Ms. Christine, and all the participants from the various countries. Participant on this occasion in our midst, there has been someone very great and very supportive for us, especially in carrying out our roles as a nurse, especially in the neurological department. In this session 1, the topic that will be discussed is a building advanced neurological teamwork. This topic is very interesting for us and very essential for us as a healthcare providers for all our patients. The first speaker is Professor Dr. Eka Julianta Wahyu Pramono, SPBSK PhD. And for now, let us watch together the curriculum vitae from Professor Eka. I will share screen for us. Let's listen together the presentation from Professor Eka. Prof. Eka, time is yours.
Thank you very much, Roy, Mr. Yi, and friends. This evening is Saturday Night Fever in Indonesia. So I would probably just like to chat and share experience with you. And not so serious, not very scientific, because scientific knowledge we can easily find anywhere else. Yeah. But experiences, actually, this is our experience due our service, the patient, and how to coordinate, how to communicate, how to organize neurosurgical team during COVID pandemic, actually. So after that, and we continue. So let me just chat with you, just like talk a story, what we are doing. This is just, of course, seriously and professionally serve the patient of neurosurgeon. And more important is how to attach one to each other. Because in Indonesia, well, everybody knows, I think not only Indonesia, but in developing country that, well, professional nurse also we need very much. But again, at the end, remuneration also very important, right? And Indonesia, we can't not talk too much about that, because that's authority of my bosses, my director. But to make them more professional, more loyal, and still high dedication in neurosurgical service, what to do, what need to be done from our side, yeah, from neurosurgeon side. So this one I want to share with you. So with us now, you can see that we are so solid in the team, and in our surgery, in our hospital, we do now is about 100 cases neurosurgery per month, and sometimes also may doing about 8 cases per day, and that is need a very high dedication, not only neurosurgeon but all of the nurses, OT staffs, ICU staffs, emergency staff, and everybody. So again, let me share with you how could we build the team, how we can organize the team to become solid and happy to do it and high dedication. My nurses, my staff working is timeless. Whenever in the midnight, early in the morning, we do it. Yeah, I will show you how we build the team and how the team is really compact. And now we have 28 neurosurgeons working in 41 hospitals in Indonesia. You can imagine Indonesia is 17,000 islands, and east to west, we need to fly 9 hours. So that's a big effort to organize them into one system. Okay, let me just chat and discuss with you again, not too much serious content, yeah, but again, maybe just inspire all of you how to build a team. So I always remember what Dr. Albert Schweitzer said, that the purpose of the life is to serve, to show compassion, help each to other. And this one we need to always show to all of the team. So this picture, when we visited the very underdeveloped part of Papua, so the tribes live in the very remote area. I will show you later how to do that. And this is against the part of Indonesia. And we do a brain education for them. And this is, I say, brain education for all. So neurosurgeon and nurse and staffs working together to promote the neurosurgery to everybody. Everybody means student, businessmen, people in the village, like what you see in these pictures. It's so varied. This is what we're doing almost 3-4 times in a month. Again, started in during pandemic, and we do it until now. So this is our OT. This was designed to make the OT is beautiful, and for the patient not become stressful and anxiety when entering the OT room. So this is just to paint like a garden in the OT room, and patient happy, and of course this also will influence them not to much stressful facing very serious surgery. So this is, I showed you Indonesia map, yeah, from the east from to west. So we serve is about 9 hours flight. Next week, when you want to join us, we go to Ambon, and next month we go to Papua, to underdeveloped part of Indonesia. And this is my team. We are now 28 neurosurgeons. So this is how we share experience, neuro nurses in the remote area. You see here, this is a Hendra. This is Miss Henny from ICU. In the right below is Roy. And this is the others is from ward. So we go to the remote area almost every weekend in a team. So we go all together, 9, 10, all doctor and nurses and staffs. So this is, I think last 2 months, we visited the part of Papua so-called Asmat. So Asmat, the people Asmat, the tribes, is live in the very remote area, very far. So this is my resident taught them how to do USG because they don't have CT scan. And this is how we do public education for people, students, and also everybody. And you can imagine in this tribe, in this district, yeah, even there is no doctor. So many outsider, yeah, migrant going there, but no native becoming even doctor. So we provide two scholarship for them, and now we have two ladies, high school students from this tribe with us now. You see, this is we sometimes wire like a native to make them happy. So two of them now with us in the Department of Medical School under scholarship. When they finish, they're going to come to remote area and build their village. That's what we are doing also to promote brain education. And this is usually the ward of the hospital, still like this in some part of Indonesia. So this is another part of Borneo. This is the Borneo part. We do it there also. We make a brain education. And this is in East Timor. So fortunately, my patient of big boss of the automotive company, they always sponsor us to buy the ticket and also the accommodation. Then we can go to every remote area. You see, we have like a medical treatment for them. And also, again, important is education for students and also for nurses in the hospital in the remote area that we have doing. So we need to share to them, not only ourselves. So you can see here. So about 10 of our nurses with me in this remote area. And then we go also to the capital city of East Timor. We do so-called 3D cinema. This is the only brain education we make in cinema, 3 dimension. So we invite people to come to the cinema and they really enjoy, like the OT 3D, really enjoy that. So this is a dugong fish, very familiar. So you should go with us. And this is also in Borneo. You see that, that's Roy and friends. They touch a lot also to the nurses in this district. So this is so-called the Nias. Nias is the village of Rois. This is far in the northwest, yeah, about 3 hours fly from Java. We also make education. And you see that's also in Medan, for the public. So our principle is when you work alone, you get something. When you look in the team, you get more things. When you feel down alone, you will be collapsed. But when you feel down in a team, they will assist you. So this is our team, 28 neurosurgeon. So several times we go together outbound. This is in the river of about 4 hours from our hospital. We bring, I think, about 100 nurses and doctors. And this was in the I think last year, yeah, in the pandemic era. So enjoy barbecue at night. So neurosurgeon served nurses for barbecue. This is Professor Julius serve wine for the nurses also, and then they can enjoy together. They can dance in the night. And they just really make us more solid with the team. So again, that is very important because again, in the OT, everything is so stressful, everything is so emotional, but outbound make everybody more attached. So what we are doing, so that's why also our nurses has really very, very high dedication compared with other nurses in other hospitals, because we many times make a outbound like this. So this is neurosurgeon, you know, serving the dinner. We have like a very special dinner at night for nurses, and neurosurgeons becoming the servant. So this is when we began 1996. You see this, Professor Yoko Kato is there. So she came with Professor Kano at the time, 1996, almost every 2 months. Help us, donate everything for us, almost every 2-3 months. And she paid everything herself, air ticket, accommodation. Then that creates something while we starting a new hospital at the time. That's the system now I apply when we have a new salon, we come together, we make a surgery all together with them, automatically we'll teach them how to do it better. So this is not the case that we have also foundation, because Indonesia healthcare system still very poor for neurosurgery cases. So for instance, this lady is a poor family. She has a giant cavernoma in the brainstem, more than 5 centimeters with the sitting position. You see, this is very dangerous procedure, but anyway, we have to do it because this is the best way to evacuate the giant cavernoma, which located in the pons midbrain and extended to the thalamus. So you see, this is a lot of effort from the doctor, from the anesthesiologist, also from the nurses. Again, to make them happy to work together with a high dedication, with a loyalty, then we need to get attached with another program I showed you before. So this is another charity program we're doing for the poor girl. We do us free. In our system, in the Brain Foundation, when the poor people come, we do it free for the fee of the doctor, of course. And we fundraise for the expenses of the hospital. So this is again when we are going rafting outbound. This is, I think, about more than 100 nurses and doctors and staff, security, all together. Otherwise, you cannot pay for their dedication. By doing this, they are becoming so attached with us and they understand that this is important. So that is our team. Share what you have and what you know to other who need it. So this, we going many times to the remote area, especially in Papua. This is Papua. So we do microsurgery in Papua, in the capital of the province, and we teach them how to do that. And this is to show you how to enjoy your work and life. So we understand working in the OT, working in the ICU is a lot of stressful, not only for the doctor, but also for the nurses. I understand. That's why we need to enjoy life. This is the giant aneurysm coming from from Borneo. This is a very special case, very stressful. We need to gather here. We are very stressful when doing this. Then we need to do something to enjoy the life. This is, we make a firework, Professor Julius, and again with nurses, this is Roy as a master of ceremony in the night. So we dance together in the island, small island in the middle of the river. So this is, we make a championship. Who win, they can have like an award. So sometimes also not every cases are successfully be done. Sometimes patient also died after surgery, and sometimes we need to come to show our sympathy to the family. This is just something attitude we need to show them. This is working in the remote area. I show you that we go to a special aeroplane to go to this place. So you see, this is a small aeroplane.
Tanah Papua, tanah yang kaya, surga kecil jatuh ke bumi. Seluas tanah, sebanyak batu, adalah harta harapan.
So educating the next generation. So I always recruit the younger neurosurgeon, younger nurses. So in case someday we have to go to pension, they are already ready for us. So do something to the country. This is the last dance we do when we visited Papua. So this is the tribe, and we need to attach with them, dance with them before we doing education. Then they will gather us as a big family. Then that make us easier. to do brain education, health education for them. At the end of our journey, life satisfaction and happiness can be achieved when we contribute something, and with nothing to give, life feels meaningless and empty. I thank you very much for your attention. I hope this funny story, this unofficial story will inspire you how to build, how to organize a good team. So again, not only knowledge, not only talking about salary and remuneration, but how to build a big team, need outbound, need something to do like that. I thank you very much, Roy.
Okay, thank you, Professor Eka, for the great motivation and your presentation for us, and very inspiring all of us. Ladies and gentlemen, it's important for us to support each other and sharing our knowledge to others. Furthermore, I gave the opportunity to Professor Salim Abdul Rauf to give some comments maybe for the topics before. Professor Salim, time is yours.
Yes, please. Yes, thank you so much. That was an excellent presentation. I think really the concepts that were discussed, essentially the teamwork, the organization, the camaraderie among the neurosurgeons, the working together with the nurses and other healthcare workers, as was shown by Professor Eka, shows really how best teams work, whether it's in medicine or any other field. When we talk to other people in other fields, it's really the concept that ultimately delivers the best results. So I think no matter where in the world you are, whether you're living on thousands of islands or you're living in a large country like the United States, the concepts are the same. It is really what leads to success, and ultimate goal is to provide the best care for the patients, the best outcomes. And I think what we saw is a great demonstration of how these concepts are put together for the ultimate success. So thank you very much.
Okay, thank you very much, Professor Salim. So wherever you are, the concept is same. We are working together to increase the quality improvement of our quality care. Okay, furthermore, I give two opportunity also to Professor Dias Holt to give any comments about the topics before. Professor Dias Holt.
I think he's not with us, Mr. Royce.
Okay, so we can next move to another speaker, ma'am. Okay, ladies and gentlemen, thank you very much. We have listened to very interesting topic from the expert, and doing something will feel lighter when we are doing it together. But in the nursing care, especially in neurosurgery, patients requires a comprehensive team, and we must work together in a team to achieve a higher quality and also to increase patient satisfaction. It is important for us, and thank you for all of your attention. And I will return to the next session, and I give the session to Missy. Thank you.
Thank you, Professor Eka. This such motivative and very supportive Professor Eka to give us such a topic. And it is, I'm sure all nurses around here will be very impressed by what you have done, Prof. Eka. I think I should call upon my co-chair, Miss Christine, to introduce the second chair, please. Miss Christine? Miss Christine, please. Unmute yourself. Christine, can you hear? Okay, never mind. Now I should call upon our next chair, Miss V. Seli, to introduce our next speaker, Miss Ji Yan. Miss V, please.
Hi, good evening, everyone. I am Sally. Today, I'm going to introduce Ms. Jiang, who is my colleague. She's an advanced practice nurse in rehabilitation medicine at the Singapore General Hospital. Her role focuses in managing patients with rehabilitation needs, which includes patients with traumatic brain injury, spinal cord injury, stroke, cancer, and orthopedic-related injuries. She majored in advanced clinical nursing practice of rehabilitation care. She's a key driver in ensuring high standard of rehabilitation nursing practice by coordinating and training nurses in the rehabilitation nursing induction program. She also devotes her time to teaching of new medical officers and senior residents who join the rehabilitation medicine. Ms. Yang lead various research and quality improvement projects to enhance evidence-based practice in rehabilitation. She also facilitates the stroke support group, meeting the psychological needs of the patient and their families. As an advanced practice nurse in rehabilitation medicine, her role focuses on meeting patient healthcare needs by maximizing the delivery of nursing and healthcare services. Today, Ms. Yang will be presenting on neurorehabilitation for traumatic brain injury patient. I will share screen to present her pre-recording.
I don't think the audience can hear anything. The volume is not on.
Sorry about that. Give me a second.
Miss Lee, can you start, please?
Oh, hi. I'm sorry. I wasn't able to share Miss Jiang. I wasn't able to share screen
Please,
as
please.
someone else is sharing.
Maybe Missy can stop share the screen.
Hello, Miss Lee. You go to the option, share computer sound.
Miss we still cannot hear the
with
sound.
TBI decreased level of consciousness, experience. Hello everyone, I'm Jia Yan. Thank you, Sadie, for the kind introduction and the committee for inviting me to deliver today's presentation. So today I will share about neuro rehab for patients with traumatic brain injury. Let's start with the case study. Madam H patient with TBI was 67 years old. Male for inviting me to deliver today's presentation. So today I will share about neuro rehab for patients with traumatic brain injury. Let's start with the case study. Madam H is a 70 years old lady who admitted for severe TBI secondary to fall, complicated by skull fracture, diffuse SAH, brain contusion, and she's on conservative management. Subsequently, she transferred to inpatient rehab for neuro rehabilitation. During our multidisciplinary meeting, nurses shared Madam H pulled out the nasogastric tube and shouting during diaper change. She also tried to pull out in the wearing catheter. During PT session, she was screaming and shouting when physiotherapists moved her, and she kicked and punched the therapist and required 2 minimum assists due to refusal and agitation. ST feedback, Madam H spitting during oral trial. She verbally abused and attempted to hit ST. OT said she only followed instruction 10% of the time, does not respond to questions, and she refused participation and became agitated. She required 3 to 4 persons for showering due to agitation. So overall, Madam H is agitated, confused, aggressive, and not cooperative. So what is traumatic brain injury? It occurs when an external force applied to head, leading to alteration in brain function. As a result, the person with TBI decreased level of consciousness, experience post-traumatic amnesia, and change in behavior and cognition. So this is the TBI statistics in Singapore General Hospital. The graph showed the median age of the patient with TBI was 67 years old. Male is more than female. There was a unimodal age distribution with a peak in loose age between 70 to 79 years old. And this graph showed fall was the leading mechanism of injury, followed by low traffic accident, RTA. More patients less than 60 years old were involved in assault, RTA, and sports than loose age more than 16 years old. Brain injury severity is the primary factor in predicting the injury's impact on individual. Patients are classified as having a mild, moderate, or severe brain injury according to a level of consciousness at the time of initial assessment. Various measures of altered consciousness are used in practice. Common measures including GCS, the duration of loss of consciousness, and duration of post-traumatic amnesia. So the Glasgow Outcome Scale, GOS, used widely to measure the long-term outcome of TBI patients. It includes a 5-point scale, GOS, and also 8-point extended scale, GOSE. So compared to GOS, and GOSE is more sensitive to change in function. As shown in the table, the score ranges from 1 to 5. 1 refers to death, 5 refers to good outcome. However, age, length of coma, post-traumatic amnesia, as well as neuroimaging also have a threshold values to predict the prognosis. Evidence suggests that age influences one's recovery following injury. Individuals in older age have poorer outcomes when compared to younger individuals. And length of coma, if less than 2 weeks, patient unlikely has severe disability. However, if more than 4 weeks, meaningful recovery is unlikely. For length of post-traumatic amnesia, less than 2 months, unlikely has severe disability. And if neuroimaging showed involvement of deeper structures were involved, which relates to poorer long-term outcome. This is a summary table showing the common assessment tools used in TBI patients across their journey from acute hospital to the community. In inpatient rehab unit, FIM score, DRS, and Rancho Rose Amigo scale are commonly used. And this diagram illustrates the rehabilitation model of care from patients sustained acute brain injury to outpatient rehab setting. Research showed intensive daily rehab more than 4 hours improves disability faster than traditional rehab. And early inpatient rehab within 35 days from acute brain injury associated with reduced coma duration, reduced length of stay, higher cognition at discharge, and greater likelihood of discharge home. Earlier outpatient rehab is associated with better outcomes. And the journey of neuro rehab, including cognitive and behavioral rehab program, community living opportunities, home rehab services, care arrangement, prevention initiatives, and vocational rehab. So principal interventions involved in TBI neuro rehab, including restorative, compensatory, environmental, and behavior. TBI typically involves a wide range of impairments affecting physical, neurocognitive, and psychological functioning. These are the common complications of TBI. I will elaborate further in the following slides. Post-traumatic amnesia is one of the most common complications after TBI. It presents in about 70% of admissions. So PTA is defined as an immediate and traumatic loss of memory that TBI can cause, meaning the individuals with a TBI are unable to effectively encode or retain new information and experience. And the duration varies from days to months. It compromises of both retrograde and anterograde memory loss. And length of PTA is a strong predictor for severity of TBI and long-term outcome. This chart demonstrates the relationship between the duration of PTA and the likely outcome in individuals with TBI. The longer the duration of PTA, the poorer the outcome is. And these are the assessment tools used to monitor PTA, including Gawastone Orientation and Amnesia Test, Westmead Post-Traumatic Amnesia Scale, and Orientation Log. All these assessments should ideally take place in a quiet room, and they should not have obvious cues like clock or orientation chart nearby. And the test only can start when the patient has regained consciousness and can communicate intelligibly. The ideal time to test a patient is when they are most alert, and the test can be stopped when the patient is out of PTA. So I will elaborate further about each assessment tool. GOAT was the first measure created to test for PTA, and the assessment consists of 10 items regarding orientation to person, place, and time, as well as memory of events both after and before the injury. The GOAT provides an objective assessment with a standardized cutoff for the presence of PTA. However, it is not well suited to assess patients with aphasia. And patient considered out of PTA if a score greater than 75 is achieved to 2 consecutive administrations. And Westmead PTA scale is commonly used in Australia and New Zealand. It consists of 12 questions that assess orientation to person, place, and time, and ability to consistently retain new information from one day to another. So it is administered daily till patient achieve a perfect score of more than 12 across 3 consecutive days. The limitation is this assessment need to be consistently administered by the same person, as the patient need to recognize the assessor's face. And lastly, this is the orientation log we use in SGH rehab unit. All log measures orientation to time, place, and circumstance. It can be used for assessment as well as monitor the progression of the treatment. Total 4-point scale with maximum score of 30 based on degree of prompting that patient needs from examiner to give correct response. Higher rating equal to less prompts needed. And patient is considered out of PTA if score is more than 25 in 2 consecutive days. And this is the Rancho-Rose Amigal scale. It is another assessment tool used to describe the behavior and cognitive patterns found in TBI patients. It can be used throughout recovery. It also facilitates communication among healthcare professionals and aids in treatment planning. In this scale, each level is presented as a behavioral description in narrative form. An assessor must decide which level best describes the patient's presenting behavior, which from level 1 to level 8. And commonly seen in inpatient rehab setting are patients at level 4 and above. And also based on the descriptor, our patient Madam H was at level 4. She was confused and agitated. So post-traumatic agitation is a state of aggression during PTA. This state occurs in an absence of other physical, medical, or psychiatric causes. It also broadly defined as a state of confusion that follows initial injury, characterized by disruptive behaviors. It occurs in approximately 33 to 54% of patients with TBI. It can last 1 to 14 days or more and decreases when cognitive functions improve. So the Agitation Behavior Scale, ABS, was developed to assess the nature and extent of agitation during the acute phase of recovery from TBI. The ABS should be administered by a nurse or a clinician and should take place over at least a 30-minute observation period. The ABS consists of 14 questions regarding observable behaviors and asks to rank the intensity to which that behavior is present. Total scores of 21 points or below are classified as normal behavior. So how to manage post-traumatic agitation? Involves multidisciplinary approach to evaluate the behaviors, to find out the triggers, frequency, and intensity, give positive and negative reinforcement, and importantly, we can use antecedents, behavior, and consequences model to assess the triggers behind those behaviors and what is the consequences. It is essential as it impacts a person's decision making in continuing or stopping to engage the behavior. And importantly, include family in plan, provide education to staff, and create a plan how staff should act before the behavior starts. So for environment change, provide a quiet, calm environment, limit number of visitors to 1 or 2 at a time, establish a reality orientation by providing orientation charts, establish daily routine activities, avoid overstimulation, ask family to bring familiar objects such as family pictures, consider to nurse patient in a single room or TBI room. So for healthcare workers, demonstrate calm behavior, speak in soft voice and low tone, provide frequent reassurance, do not confront or attempt to deal with physically aggressive patients alone, redirect patients' attention, avoid sudden changes, and have consistent staff to look after patients. Remove nauseous stimuli such as non-necessary tubings or cannula, give short instruction, and use repetition if necessary. Educate family to understand PTA and how to minimize triggering agitation. Avoid restrainer if possible. This is the TBI room in our rehab unit. We have CCTV monitoring at TBI room, so nurses can monitor patients' behavior through a TV screen at the nursing counter, and the wall of the room was padded to prevent injury. Agitation is often accompanied with behavior disturbance, such as disorientation, aggression, restlessness, and disinhibition. It is a common neuropsychiatric disorder post-TBI. It can pose significant barriers to initial acute medical treatment and to long-term rehab and recovery. So how to manage behavior disturbance? So for disorientation and confusion, introduce yourself and address patient by name is important. Avoid overstimulation and create a routine schedule of activities. Explain to patient what you are going to do and provide daily orientation. For restless and wandering, redirect in a positive manner. Come with me instead of don't go out. And put patients back near nursing station for close observation. Distract patient with activities and anticipate patient's needs and physical comfort level. Identify triggers. Ask family for supervision and consider restrainer if other methods are really ineffective. And for this inhibition, firmly and clearly point out inappropriate behavior. Give clear, simple, and unambiguous feedback. No touching, for example. And feedback must be a matter of fact and firm without emotional tone or shock or nervousness. And also develop consistent way of dealing with inappropriate behavior with staff who are attending to patient, which is essential. And sleep disorders are one of the most common and persistent sequential of TBI. It has been reported in 30 to 70% of patients with TBI up to 3 years post-injury. So chronic sleep disturbances can result in persistent impairments in cognition, behavior, and emotional function. And the most common disturbances are insomnia and hypersomnia. So we use sleep-wake cycle observation chart It monitors patients' 24-hour sleep and weight cycle. It helps to look for pattern and initiate treatment as well as assess the outcomes of the treatment, which including non-pharmacological and pharmacological treatment. So non-pharmacological management options including lifestyle modification such as exercise, occupied patient during the daytime, relaxation technique, and for behavioral interventions including cognitive behavioral therapy and provide education on sleep hygiene, as well as complementary and alternative medicines such as acupuncture and bright light therapy. And non-pharmacological interventions may be initiated with pharmacological strategies, so medication options that including like melatonin and antidepressants. So besides behavior and sleep disturbance, survivors of TBIs often have cognitive impairments. It is seen in 65% of moderate and severe TBI patients and caused by both primary and secondary injury mechanism. So cognitive recovery predicts successful return to work and independent living. So cognitive dysfunction can negatively affect many areas of cognition, such as attention, memory, executive function, learning, communication, and social skills. So each of these functions represents a unique area of cognition that allows individuals to execute basic or instrumental activities of daily living. So MMSE and MOCA are two common outcome measures to evaluate cognitive function. MMSE is one of the few measures least affected by comorbid mood disorders in TBI. The assessment consists of a brief questionnaire that requires the individual to respond verbally, perform an action, and reproduce an image. A score below 24 is considered cognitively impaired, and further assessments are recommended to determine the specific cognitive impairment. And MOCA is one-page assessment that evaluates the cognitive and cognitive communication components for a total score of 30. A score below 26 is considered cognitive impaired. One consideration when using the MOCA is heavily language-based, and therefore is not ideally for individuals with significant aphasia and language deficit. So neuro rehab in cognitive impairments. As many as 60% of individuals with TBI reporting attentional difficulties after injury. So rehab strategies including the following. Dual task training are the most common effective non-pharmacological interventions, also including virtual reality, computer-based intervention. And goal management training, GMT, which consists of a structured program that aims to help individuals to identify and achieve goals. An example of a series of steps an individual can identify through the GMT to execute a specific goal. So we're using this example like getting groceries. Brain stimulation. So use transcranial direct current stimulation, which painlessly delivers electrical currents to specific brain regions to modulate neural activities. And methylphenidate is the most supported pharmacological intervention for attention, which we commonly use in rehab unit. So learning and memory deficits are defined as the problems with the encoding, consolidation, retrieval of new or old information. The focus of rehab will be restoration, retraining, and compensation of deficits. These are some of the interventions using external technology aids such as smartphone, organizer, calendar, virtual reality, internal memory strategies. This is the most common and successful techniques. Time pressure management training, dual encoding are examples of internal memory strategies. Also have learning and memory training. Medications such as donepezil and rivastigmine have strong evidence for improving memory and learning following an acute brain injury. Executive function. Executive functions are generally defined as loose functions including complex processes such as goal setting, decision making, problem solving, and long-term planning. Executive function rehabilitation including general cognitive training programs such as problem solving, group-based interventions, and community integration, mindfulness-based stress reductions. Also, administration of human growth hormones appears to have some positive effect on general and executive function in those with TBI. Verbal and written communication is the ability to improve expressive language, speech production, reading, writing, and cognition. And these are strategies commonly used in neuro rehab to improve communication, which including environmental and behavior modification, retrieval practice, targeted figurative language, as well as targeted speech and language therapy. And lastly, social skills. Social skills are our ability to perceive, interpret, and respond to situational demands. Impaired social skills have negative impact on social, vocational, and academic competency. So neuro rehab in this domain including social communication training, no verbal communication, and using AAC. So patients with severe TBI may not able to meet the communication needs through speech alone. So pictorial, picture symbol-based boards or alphabet boards are alternatives. And the success of communication interventions often relies on the understanding, compliance, and competency of communication partners. The training is particularly helpful in successfully facilitating communication with those who have TBI. So the strategies include speaking in short, simple sentences, making and maintaining eye contact, and asking the patient to repeat the message being given and minimize distraction. Besides cognitive impairments, survivors of TBIs often have functional impairments, which depending on the severity and location of injury to the brain. They may experience some of the following signs and symptoms, such as numbness, weakness, and stiffness of upper limb and lower limb, uncoordinated movements, dizzy when turning around, unsteady gait. So early rehab is important when they are medically fit, and precautions is needed to take while exercising or moving TBI patients. Do not move then if patient is aggressive and agitated. Also be aware the presence of other injuries such as fracture. Importantly, to engage a TBI person. So to engage them by preparing the environment, choose a quiet environment to encourage attention to the task, and remove clutter to prevent injury, to break down a task into steps, and keep commands short and simple. To remember to allow time for them to respond. And perform range of motion and balancing training as well as functional mobility is important as well. Sexuality. Sexuality is a normal part of life, but often under addressed by healthcare professionals. So persons with TBI can change their sexuality. More often, caregivers may notice sexually inappropriate behavior, and these behaviors are likely a result of this inhibition. On the other end of the spectrum, a person with TBI also experiences physical, mental limitations to engage in sexual activities and reduce sex drive. So these are some of the strategies, including feedback must be given and avoid tones of discomfort and disapproval. When prohibiting inappropriate behavior, it is helpful to follow up with a suggestion of a permissive behavior or a distraction, so that the person with TBI will not fixated on an inappropriate behavior. For example, you can say no touching, go and get a glass of water. Also checking their understanding of the feedback by asking them to repeat the information. And manage the environment, reduce inappropriate behavior. So observe the situations where the behavior is more likely to occur and restrict any opportunities to engage in inappropriate behavior, and try to provide alternative activities such as socializing in small group rather than large group, and educate them and provide reminders about the need for privacy and identify appropriate places and times, and to consider to refer them to specialists for sexual dysfunction. So through the journey of TBI, there are huge impacts on family and caregiver as following. So provide counseling and caregiver support are essential. So share with them it's okay to accept help and suggest preparing a list of ways they would like others to help with. and to focus what they are able to provide. And let them know it is normal to feel guilty sometimes and understand that no one is a perfect caregiver. And set a realistic goals, prioritize making lists, and establish a daily routine, and find out about the caregiving resources in the community, and establish opportunities to meet other caregivers to get support, and seek social support and making effort to stay well connected with families and friends who can offer emotional support. That's very important. And take care of their own health and see doctor if they have any concerns or symptoms, especially the symptoms are affecting daily life, such as crying, insomnia, or suicidal thoughts. So non-pharmacological management is important for neuro rehab in TBI patients, and pharmacotherapy is also increasingly being used in both the subacute and chronic phases of TBI. So medication should only used as a last resort with the principle of start low and go slow, to be alert with the side effects and undesired effects of the medication, and avoid using benzodiazepines and neuroleptic antipsychotic medications which slow brain recovery. These are two common medications we use for patients with sleep disorders. Trazodone is an antidepressant with sedation effect, which is useful to treat insomnia after TBI, and the side effects including drowsiness and seizure. And melatonin. Melatonin is an endogenous hormone, plays a role in regulation of sleep-wake cycle. It helps to improve sleep quality and increase the sleep efficiency. And this medication is safe to use with minimal side effects. And common neurostimulants we use are methylphenidate and amantadine. Methylphenidate improves attention and cognitive performance, can be given once or twice a day. A total daily dose of 20 to 30 milligrams, but do not exceed 16 milligrams per day, with side effects of insomnia and reduce the threshold of convulsion. So amantadine increase both motor and cognitive recovery. Side effects are nausea and seizure. Lastly, are antipsychotics for behavioral disturbance. So quetiapine, we commonly use to help with TBI patients with agitation where no pharmacological interventions have been exhausted. Haloperidol, seldom used for TBI patients, as research showed it has no benefits for aggression control in this group of patients. It also has negative effects on TBI recovery. Okay, so let's come back to the case study. Madam H. So these are some of the interventions we carry out for her during inpatient rehab stay. So for her insomnia, we monitor her using sleep-wake chart, and we started on melatonin. We also provide daily orientation to her. In terms of agitation, we monitor her use the ABS scale, orientation log. At initial stage, we also keep her in the TBI room for her safety. And importantly, we try our best to remove the stimuli such as tube feedings and also IDC. Importantly, we involve the family in education, and this is also involved in multidisciplinary team such as PT, OT, ST. So a brain injury impacts are often profound and lifelong, leaving many survivors and caregivers feeling hopeless. And this is where support resources become crucial. And this is a TBI booklet we developed for both patients and caregivers. It is a very informative booklet, which including the information about TBI and the tips on how to take care of TBI patients, as well as all the available community resources and caregiver support group. And this booklet will give to caregiver upon patient transfer to our rehab unit. And Life with the Traumatic Brain Injury is a book written by a TBI survivor, Amy Zemmer. She sustained a brain injury after she had a fall in 2014, and her life has changed totally after. So this book is a collection of her stories. I feel this book is very good to read. It helps the caregivers to understand about what it means to have a TBI when they read about her struggles and frustrations. And this book also perfectly good for healthcare workers as well, because it not only offers insights and details on brain injury, it also sheds light on often overlooked and misunderstood issues by us. So this is my last slide. I would like to end my presentation with this quote from the TBI survivor. You can do the impossible because you have been through unimaginable. So with this, thank you very much for your attention.
Thank you, Ms. Zhang, for the insightful sharing. Sorry for the earlier technical issue. So unfortunately, Ms. Zhang is currently overseas with limited internet connection. Therefore, she's unable to join us today. However, she has said that if you would like to ask any question, you can email to her directly. May I trouble Ms. E to give the participant Ms. Zhang email if there's any question pertaining to her slides?
Yeah, sure.
Okay, thank you. Can I hand over to the next speaker? Ms. E, will you be introducing the next speaker?
May I call upon Professor Salim to give us some comment on neurorehabilitation? Prof. Salim?
Yes, I think the concepts that were discussed in neurorehabilitation really covered everything that that we would discuss in this area. I think the closed head injury and severe head injury remains one of the biggest issues that we deal with in healthcare in the field of neurosurgery. And I think training and education of the students, residents, nurses, in looking at rehabilitation, even while the patient is in the hospital, in the ICU, and to connect the families with the long-term care is very important early on in the care of the severe head injury patient. So when the patient is in the ICU, they go to the floor. I think the education of the family across the board from the beginning about what this journey is going to be and having the right expectation is critical, so that the family knows what the long-term journey is going to be in this process. So I endorse a lecture that was given, and as my final comment, I just want to say, based on both lectures that we listened to, the critical issue I saw here is education, which is critical early on for the students. It's something that I have been committed to in my whole career. And I just want to show you a quick picture from 2 weeks ago, where we have had students going into neurosurgery from all over the world. We met in Granada, Spain. This is at Alhambra Palace. In Spain, where I'm with the next generation of neurosurgeons going into neurosurgery. And this is really what it's about, is for us to have mentorship with the next generation in educating in all these models and working together, the neurosurgeons with the nurses, with the neurologists, with the rehab experts, in a collaborative fashion, in and multi-teams working together under one system. So I think these lectures were excellent because they show the collaboration between the various specialists, and I appreciate being with you all here today. Thank you.
Thank you very much, Professor Salim, for the kind comments. And now I should call upon our third speaker, Miss Sunny, to share with us her case report on neurorehabilitation. Miss Sunny, please.
Thank you, ma'am. Hi, everyone. Just a minute to share my screen. Okay. I'll be presenting neurorehabilitation, a case study. And as told by all previous speakers, neurorehabilitation is a continuous process and which require the treatment need to be initiated and constantly revised and updated based on therapy-mediated improvement of the client. And it aimed to minimize the disability caused by the initial event, as well as help the person to adapt to the new situation by learning new skills or using some adaptive devices. And quite sure that neurorehabilitation is a challenging process, especially in patients with dysfunction of brainstem or in pediatric patients. It will be really challenging. And the rehabilitation plan need to be individualized. That is, it should be tailored to the individual needs. And of course, many professionals are in a part of a neurorehabilitation team, but the nurse play a pivotal role in the process of neurorehabilitation. And I'll be presenting a case or presenting the care of a child as he had gone through the neurorehabilitation process. So my child is a 10-year-old boy. He had a normal development and immunized up to age. And he only had a past relevant history of operation of for a PDA ligation at the age of 5 months, and thereafter no sequelae of that problem. And he is referred to our center with the diagnosis of cervicomedullary lesion. That's a tumor involving lower medulla and upper spinal cord. And how this illness started was that the parents were noticing drooping of his right shoulder around 3 years back. Later, around 1 year back, he developed tilting of neck to right side, and he developed mild to moderate pain radiating to, that was not radiating around 1 year back. And around 2 months back, he developed weakness of right upper and lower limb with bilateral numbness of both foot plantar aspects. And in the 2-month period, he was shown to local hospital and had the diagnosis, which was shown by me previously, and he was referred to our center. While admitting to our center, the child was conscious, alert, stable, with stable vital signs, and GCS was full. And his pupil was equal and reacting, and his cranial nerve functions all were normal. His muscle bulk and tone, everything was normal. And his muscle power in the right side was 4/5, and in the left side it was 5/5. And he had a leaning right, and he had a torticollis towards right side. All the blood investigations were normal, but MRI brain and spinal cord showed a well-defined lesion within the fourth ventricle extending to lower medulla and upper spinal cord level up to C4, suggestive of a brainstem glioma with cervical intramedullary extension. And syringomyelia seen from cervicothoracic spinal cord up to corners. And the surgery was done, and after modified suboccipital craniotomy, gross total excision of the lesion was done, and C1, C2 laminectomy and C3 to C5 laminoplasty was done. The histopathology report showed it is a grade 1 pilocytic astrocytoma of the fourth ventricle and intramedullary cervical spinal cord. In the postoperative period, we received the child in a conscious and stable vital signs, and the child was on ventilator. But because of this medullary problem, we were not able to wean off the child from ventilator. And in the first POD, the child developed paraparesis that may be due to cord edema, and the child had a cranial nerve dysfunction, leading to make us to think that the child may require prolonged ventilation. So in the postoperative period, electively, we have done a tracheostomy to aid in weaning and to prevent aspiration. So the weaning process was prolonged, and in the future coming slides, I'll be narrating the nursing care aspect in the in some headings. as the child had grown through the entire rehabilitation process. One is respiratory care in the background of medullary failure added to the cervical spine dysfunction. And another area was to improve the muscle power and prevention of loss of muscle bulk. And another area was prevention of deep vein thrombosis, skin care, nutrition and feeding, and care of bowel and bladder, developmental needs, and supporting the family. These are the headings in which I'll be highlighting the important nursing care points. First one is respiratory care, and because of this medullary dysfunction and the cervical spinal cord dysfunction and cranial dysfunction, we have an anticipation that child require a prolonged ventilation. So initially, planned and elective tracheostomy was done, and we were started intensive chest physiotherapy. We have given humidified inspired air, and nebulization was done, given frequently to thin out the secretions, and turning and vibration was given to mobilize the secretions, and frequent suctioning was given to suck out the secretions. But even after this intensive therapy, the child developed consolidation in the immediate post-operative period, but that was treated with proper pulmonary toileting techniques. And next, the weaning was a real challenge because the child had, I already discussed, medullary dysfunction, cervical cord dysfunction that resulted in paraparesis, that is musculoskeletal weakness of the intercostal muscles and abdominal muscles. Added to that, the child had a lower cranial nerve dysfunction also. So in that scenario, what we can do is we have to go for a slow and gradual weaning. It is a process of conditioning the respiratory muscles, and we have to start supporting the child's breath with coupling with the ventilator. Slowly, we started the weaning mode and gradually progressed to twice daily TPS trials, and slowly we increase the frequency of TPS duration, and we ensured that at least 4 to 5 hours of rest for the child to prevent fatigue of intercostal muscles and diaphragm. And the physiotherapist used a lot of breathing techniques like resistant abdominal breathing and intercostal muscles resistance training to strengthen the intercostal muscles and abdominal muscles. And we did not do the assisted cuff techniques because the child was so fragile to compress the intercostal muscles. And electrical nerve stimulation was also not done for the fear of burns because the child had loss of sensation also. But we were using resistance training to abdominal muscles as well as intercostal muscles. And for improving muscle power and preserving muscle bulk is very much important, and we have initiated passive limb physiotherapy in the first post-operative period itself, because the nervous system has the capacity to adapt and rewire by itself, so that the lost functions or the functions weakened can be restored. And intercostal abdominal muscle strengthening, I have discussed already. And we used the braces, TK brace for proper musculoskeletal alignment by ambulating the child. And this child tolerated an supine position rather than an upright position. And it is quite said that these type of children as well as adults tolerate a supine position well because of lax abdominal muscles. And in order to prevent food drop, we used a food support, and ultimately with the support of brace, we could ambulate the child to wheelchair. But we could not do weight bearing exercises, but this child only developed the muscle power of distal muscles, but he had a fair neck control, but the trunk was very weak, so we could not do weight bearing exercises. But in order to preserve the muscle bulk, we could do resistance exercises. That is, in passive exercises, the therapist applied resistance against it to preserve the muscle bulk. Next area, very much important for a pediatric patient, is that feeding and nutritional status. The child had a basic weight of 24 kg, but as the weaning process started, the child was in high metabolic demand, and he reduced almost 8 kg of weight. But immediately after the tracheostomy, we have started trials to feeding, but a dietitian consultation was done to start a high protein and high calorie diet. around 2000 kilocalorie diet with 50 grams of protein was the planned diet, and it was included in a 1800 ml of fluid, and we started rice to feeding. But the child had a intensive salivary drooling, that is the cough and swallowing reflex was absent, and he was continuously drooling saliva. So we consulted the speech language pathologist, and they identified oropharyngeal dysphagia with severe nasal regurgitation. So we were sticking on to rice to feeding, and child was on tracheostomy also. But gradually the child started swallowing saliva, so we thought that swallowing might have improved. So again we did assessment with the speech and language pathologist, and we started a semi-solid diet in presence of tracheostomy. The child tolerated well, and but fluids and other medicine we given through the rice too. And for bowel and bladder, fortunately, this child attained bowel and bladder control very early, and we were giving regularly stool softeners, and child was wetting diapers, and meticulous skincare was given to prevent pressure ulcer. And since this child had a paraparesis, there is venous stasis and higher risk of DVT. So we were using pneumatic compression devices in both legs, and passive exercises and turning every 2 hours early. And pharmacological prophylaxis was also started to prevent DVT. I already discussed, we were very much meticulous in caring the skin. We turned the child every 2 hours early. Initially, actually, we felt it is very difficult to turn the child because the child had a torticollis, as well as the stabilization of tracheostomy was very much difficult in the early period. And added to that, the child had a medullary dysfunction also. I'll be coming to the history later on. And we were giving back massages to improve circulation, and we were giving daily bath with soap and water. And we were using head rings and cushions, and moisturizers were used to exfoliate the dead tissues. And regarding his developmental needs, how we addressed was that in general, this child was very cooperative and friendly, and he became awake very soon. Within 5 or 6 days, he was very alert and cooperative, and he started communicating with nurses with lip movements, and he can very well hear and understand what we are telling. And as he became stabilized, and we started oral feeds that increased his confidence, and he participated in rehabilitation activities with very interest, and he demanded in tracheostomy, he demanded for care, diaper change, as well as his favorite food. That also encouraged us to provide more care and support to the child. And how we support the family was that in our hospital, we usually don't allow the relatives to come near the patients, but the doctors and nurses were frequently communicating to the relatives regarding the condition of the patients. But for this child, since he had a prolonged stay and his condition requiring a prolonged period of rehabilitation, we were giving family time twice daily, around 5 to 10 minutes. They were visiting the child, but the child, after 5 minutes, he'll be telling bye to his mother and father. He want more time with the nurses, and we had a fun time there. But at the close to the time of transferring to ward and discharge, we were educating the parents regarding home care and how to give physiotherapy, and everything we were teaching to the family members. And this child had a prolonged hospital course around 4 months. And during that time, because of medullary dysfunction, he had desaturations and total cardiac arrest, complete systole for 3 times. But we could successfully resuscitate him to normal. And in between, he developed severe electrolyte imbalances, acid base imbalances. All those were detected very early and corrected appropriately. Even after meticulous skincare, the child developed 3rd degree pressure ulcer to the occipital area. That is, the child had a torticollis. So initial 1 to 2 weeks, we were not able to care that area properly. He developed a 3rd degree pressure ulcer there, but that was healed immediately after that with proper dressing and cleaning and change of position. But around after 4 months, we could ambulate the child to in a wheelchair, and tracheostomy was closed. At the time of discharge, the child was conscious, completely conscious, alert, cheerful. He was ambulated to wheelchair. talking and accepting oral feeds. His muscle power was 3/5 distally and proximally it was 2/5. Again, he need prolonged rehabilitation. His bowel and bladder were continent, and we advocated for DVT prevention, physiotherapy, and high protein diet to be continued in the home also. And we advised the regular follow-up. This is about my case study. To conclude, rehabilitation of patients with neurological disability is a long process, and especially with patient with brainstem dysfunction was require a multidisciplinary collaboration, and nursing staff with necessary skills and to cooperate and collaborate with the individuals in their care and with the other staff can create an environment in which the individual can learn a more productive coping skills which assist them in their own recovery process in a much more effective manner. That's all about my presentation. Thank you.
Thank you for your presentation. And I remain most grateful for the right attention. And now we can hear for the comment from Professor Yoko Kato. Prof,
Yes, yes.
time is yours for give a comment.
Okay. So thank you so much. I'm so sorry because I missed Dr. Eka, the great lecture tonight because overlapping some webinar. And but I'm very happy to listen the nurses the lectures. The neurorehabilitation is one of the most important part of the especially the neurosurgeon's patients because after the acute stage of the treatment, we most of the case we ask a neurorehabilitation doctor and nurses, and I think some treatment by you is maybe decide the future life. I think and that means is so many you can teach the multifunction of the starting from the brain function and also the physical function. I think it's really appreciate your daily activities, and we learned a lot. And also the Shani. Okay, thank you very much for a nice presentation and very precise even case report. In Japan, we have so many division of the even the neuro the nurse. So, but in India, maybe you do the yourself so many part of the treatment of the patient. Can you tell us now?
Regarding what, ma'am?
The patient care, because from A to Z, so you do everything.
Yes,
on one nurse.
Yeah, actually, we don't have a patient caregiver near to patients, even in the wards also. So the entire care of the patient is taken care by the nurses only. From the assessment to feeding daily activities of daily living, everything will be taken care of by nurses, and we'll be having nursing care assistants who are helping us. And regarding what care?
So what about the psychological care?
Actually, we are talking to the patients, and we'll be, as the patient awake in the next day morning, we'll be encouraging the patient to talk to the relative over phone initially. But later we will call them, and twice daily we will make the patient seen by the relative, and the condition will be explained to the relative by a doctor itself. Twice a day, so that the patient will be patient's relative will be comforted, and their apprehension will be reduced, and patient's psychological need has to be reduced by nurses talking, consolations, explanation about the disease condition, the prognosis, and the probable course of the disease. We have to tell them clearly so that their tension can be reduced a lot.
Yes. So what about the Singapore and also the Indonesia? Do you do everything by nurse? Ms. Lee, please.
Oh, and so in Singapore, we also plan the care for our neuro rehab patient. The only thing we do extra is I'm sorry, I should say that we work closely with the medical team as well as the therapists. So it's a multidisciplinary approach. It's not a one-man show. So we are very close to the team. So the doctors actually listen to our advice, and we have a weekly multidisciplinary meeting whereby we meet up with the therapists, the doctors. So we work very closely as a team to provide better care for our patient.
Good, great. What about Junie?
Yes. In Indonesia, same with Wiseli, we have a multidiscipline team, Prof. And for the especially for the physiological, maybe we can collaborate with the physician, and for the nurse, maybe we can talk anymore with the patient and for the family. Thank you, Prof.
So I saw the several the male nurse. Hello. Male nurse. Either the name is Roy, Sonny Roy.
Yeah, Prof. I'm here.
This is hi, nice to see you.
Hi, Prof. Nice to
Can
see you.
you tell us something about you're the nurse practitioner?
Oh yeah, in here, a specialist to rehabilitation patient. We don't do it by ourselves, but we are collaborate with another discipline, with physiotherapist, and also basically also about our from our advice, and we can collaborate also with the physician how to improve the quality care of the patient.
Okay, thank you very much. Thanks. So, the Mrs. Sister E, please, back to you.
Okay, thank you, Prof. In Malaysia, we have very limited beds for neuro rehabilitation patients. So we will start rehabilitation in our neurosurgical wards itself. And when patients are almost ready to discharge, sometimes the neuro rehab ward will take over. And our surgeons may not happy, say patient is almost discharged, then only they take over. We are like multitasking. We will work as a team with the physiotherapists, the rehab physician, the neurosurgeons, the psychologists, from our ward itself. Once patient is able to be mobilized and is out of danger, stabilized, then we will start rehabilitation in our ward itself. So we are a bit different. I think we are vastly different from Singapore. Singapore is very advanced, and I think in Indonesia also they have a very structured team, but not in Malaysia. The general hospital, we have to do everything. That is from our side. Thank you. What about Miss Elizabeth? Can you please give us some comment?
Hello, hello.
Oh, hello.
Oh, sorry. I cannot see my face. Actually, currently I'm living in New Zealand, but I'd like to share my experience. Like last week, I went to a hospital and I visited the neuro-integrated, the integrated unit for a neuro rehabilitation, and I saw the multidisciplinary collaboration is very good. Like once the patient hospitalized and every day they have a like a conference and meeting for all the multidiscipline, and they have various profession, healthcare profession, for example, like occupational therapists, and then dietitian, and then pharmacy, and then physician and nurses. So I think it's very good. So they can provide excellent patient care. Yeah, thank you.
So tonight, do we have the Nicolay? She is a medical student.
Yeah, good
Yes,
afternoon,
hi,
everyone.
hello. Please say
Thank you,
something or give us
Professor
some comment.
Cato. It's an honor to be reunited with you again and all of your colleagues. I was very amazed to hear all the experiences from the nurses and also the talk of doctor who was presenting when I entered. It was very inspirational to see how committed he was not only to his patients, but also to the education and also having this group mentality working and all of that, because it's very important for the care of the patient. Maybe many doctors have the knowledge, but not so many of them share it, and not so many share it as a group. So I think it's very important. And I am from Bolivia, and I think this kind of mentality is what keeps neurosurgery always evolving. And I'm very honored to be here to get to meet all of the nurses. I am really inspired by all of your jobs. Thank you, everyone. And really, I would like to congratulate all of you, because hearing what you said, hearing all your work and how you treat your patients with such care, and you're very committed to them, and maybe you're like the only people in the hospital that get the chance to actually talk with the patient more in a maybe some safe way. But I think it's very important, all of the job that you do. Thank you to the organizers, and also thank you, Professor Cato, Professor Abdulraf, who was giving the comments earlier, and the Congress he mentioned at Granada. One of our members, Nicolay Antesana, he's a second-year medical student. He was able to attend, and he came with a lot of expectations. He really enjoyed it, and I think that this mentality of group playing and group working is very important, and it's going to change the path of neurosurgery. So thank all of you, and I'm very pleased to be here. Thank you.
Thank you much, Nicolay. So either the one Chinese nurse, Nicolay, hi, how are you? It was a nice shot in
Good afternoon.
Granada.
Good afternoon.
Thank you.
Yeah, thank you,
Yes.
Professor. I hope that we can get you for our annual meeting at December. We will let you reach the letter. Thank you,
Yes, yes.
Doctor.
Thank you. Thanks so much. So the Chinese nurse, Pham, can you say something or some comment? Pham Shan, is she from Vietnam?
Not sure, Prof.
Okay. So I can't read the name. So sorry.
I think it's from China, I think Chinese.
Okay, so who can make a summary? Maybe Jessica, Miss Lee. Can you make a summary the nursing session?
Oh, hi, Prof. Yeah. So I think Prof. Salim has emphasized the importance of educating doctors and nurses on the journey of neuro rehab. So I think Ms. Zhang and Ms. Chani has given a very informative presentation today on neuro rehab for adult and for a child. So we are very happy that nurses can gather together on this webinar to share about nursing care. So it's not just a one-man show, it's actually a teamwork. So nurses are very important in neuro rehab care. So we hope that we will have chance to meet up with real person the next round.
Yes.
Yeah, thank you. Thank you for inviting us.
Thank you very much. Okay, so the closing remark by Dr. E.
Okay,
See?
thank you. Thank you, everybody, for attending the webinar. And it is all very informative webinar today, especially for the nurses on the aspect of neuro rehabilitation. And as what Ms. Sally said, it is a teamwork, and we should all work together as a team to improve our patients' care, to reduce mobility and mortality. This is very important. So all of us, let's put our hand together to increase our quality of work for our patients, a better outcome. And before we end, can I just read out Ms. Jihan's email address? JIANG.YAN@sgh.com.sg. This is her email. So if you have any problem or any comment or anything that you want to inquire about neuro rehabilitation, please email to her. She is not with us today because she's overseas. Can you get the email address? So you can email her, okay? I think we have come to the end of the webinar, and this is our last session for this year, 2022. We will start our next session next year, January. I hope to get some suggestion on what are topics that the audiences required and they wish to know, especially the nurses. So I hope in future we'll get more audiences, especially nurses from all over, come together to share experience and work as a team to upgrade ourselves to improve our patients' care. With that, thank you very much, everybody, and good night. I think most of us towards the evening, I think.
Yes.